Three, two. Good morning in Miami and good afternoon in India. This is Dr. John Bennett broadcasting for IndiaMedical.tv. Dr. Suri may be up in Nepal now dealing with earthquake victims. And today we have the pleasure of having Dr. Sagar Abhichandani. He's a dentist from Mumbai, and he's in a group practice called the Dental Hub. And today, Dr. Abhichandani is going to give us an introduction to occlusion. Welcome, Dr. Sagar.
Welcome, John. It's completely my pleasure.
Okay, I guess you're going to start with the screen share with your presentation.
Yeah.
Okay. We're just learning this tech, and we'll get better. There we go. Yes, you are on.
Okay, good morning to everyone back in the United States. Good afternoon to everyone back in India. A small introduction about myself. I'm Dr. Sagar Abhichandani. I did my graduation from Mumbai. Went on to do my post-graduation from SDM Dharwad. Also went on to do my post-graduation in restorative and aesthetic dentistry, University of Manchester, United Kingdom. After that, I was a consultant prosthodontist and implantologist in various clinics in Mumbai. Ultimately set up my own practice. Some of the snapshots you can already see on screen. It's a state-of-the-art dental clinic with a 3-chair practice. We have our own in-house dental lab, a cafeteria, children's play section, which spans about 2,500 square feet in the heart of Mumbai. As you all know, Mumbai is the financial capital of India, and you see a lot of patients who are expats working in Mumbai. A lot of foreign passport holders are our patients. So we do maintain international standards of dentistry at affordable costs in Indian rupees. You don't have to pay in US dollars, you don't have to pay in Great Britain pounds. You get the same kind of treatment in Indian rupees. Coming to what we're talking today, we're going to talk about something which is very complex, something which everybody fears. It's occlusion. The word occlusion itself is complex. So the complexities associated with occlusion will be discussed as we go on in this entire series of lectures, which is going to span at least 4 days, wherein we start from the basics and keep building on the blocks such that we ease out your complexities, help you understand the basics, and then build your foundation thereof. Okay, the first session is going to be dealing with an introduction, wherein the various terminologies will be introduced to you. You will get to know what different meanings exist. We will also be determining the occlusion as far as the vertical and the horizontal determinants go. We will also be introducing occlusion in natural dentition, the different functional tooth contacts, the concepts of occlusion that exist, and mandibular movements. Now, when we are talking about occlusion, we just cannot ignore or skip mandibular movements, because during any excursion that occurs, when your mandible moves to the left, to the right, or in front, you do have tooth contact. So it is then we have to understand whether we want a tooth contact, we want an interference, we want a premature contact, or we want disocclusion, or that is absolutely no contact. So we start slowly and steadily, making sure that you're not lost in a maze somewhere. What happens is the entry point is very simple. We get stuck up midways. We do not know where to exit. Most of us have heard talks about occlusion. Many of us have also understood the different programs which exist, teaching occlusion, practicing occlusion, getting the optimal occlusal schemes right. But do we actually practice that? That's when the problem starts coming, because it's easy to understand few concepts, but it's difficult to implement those few as well. Many people are at the crossroads where they understand that if I go ahead and do it, the problem is the way out. What if I get stuck somewhere? What if I'm lost in the middle of the sea? I have no way out. So they just keep themselves at a distance, at bay, making sure they don't venture into it. But it's not that difficult. Trust me on that. We do have a way in and a way out. At the end of this series of lectures, it's something you will realize that troubleshooting, if occurs, there is a possibility. But for that, we have to start from the grassroots levels.
Oh, okay.
For a prosthodontist, what we have is the glossary of prosthodontic terms, which is our Bible. The definitions go as per the glossary of prosthodontic terms. We have different editions. We always follow the latest edition, which in this instance is the 8th edition. Starting with the basic definition of occlusion, it is defined as the act or process of closure or of being closed or shut off, or the static relationship between the incising or masticating surfaces of the maxillary and the mandibular teeth or the tooth analogues. Why the tooth analogues? In case the patient is a denture wearer or has a full mouth reconstruction, both of implant supported, implant retained, or tooth supported restorations. Mutually protected occlusion or organic occlusion, an occlusal scheme in which the posterior teeth prevent excessive contact of the anterior teeth in maximum intercuspation, and the anterior teeth disengage the posterior teeth in mandibular excursive movements. The basic idea to introduce these terms is to get familiar with what kind of terminologies will be used as and how the lecture becomes a little complex. Anterior protected articulation, a form of mutually protected articulation in which the vertical and the horizontal overlap of the anterior teeth disengage the posterior teeth in all mandibular excursive movements. Canine protected articulation, a form of mutually protected articulation in which the vertical and the horizontal overlap of the canine teeth disengage the posterior teeth in the excursive movements of the mandible. Balanced occlusion, the bilateral simultaneous anterior and posterior occlusal contact of the teeth in centric and eccentric positions. Till now we've come across six or seven definitions, and in all of these definitions you see that there is positioning of the mandible. Means we have to take into account the mandibular movements, because mandible is the only movable joint in the entire stomatognathic complex. So the different positions will encounter different tooth contact as well as no contact. So we have to understand that. Unilateral balanced occlusion or group function, multiple contact relations between the maxillary and the mandibular teeth in lateral movements on the working side, whereby simultaneous contact of several teeth act as a group to distribute occlusal forces. They act as a group function. Centric relation. This is the only definition which has been revised, re-revised, over-revised over a period of time. As of today, if you see, there are about 11 to 12 definitions of centric relation that exist. What does it signify? Centric relation is the starting point. It's extremely important to understand what centric relation is, because if we understand what the stepping stone is, we can definitely move ahead with confidence. I'll first read the definition and then explain the important points which exist in the definition. The maxillomandibular relationship in which the condyles articulate with the thinnest avascular position of their respective discs with the complex in the antero-superior or the anterior superior position against the slopes of the articular eminences. This position is independent of the tooth contact. This position is clinically discernible when the mandible is directed superiorly and anteriorly. It is restricted to a pure rotatory movement above the transverse horizontal axis. This definition at least has got 3 lines, right? This is very important. Now the few key points and the take-home messages for centric relation. The first important being is that the complex is in the antero-superior position. Gone are the days when we used to say that it's the RUM concept which is followed. What is the RUM concept? RUM stands for R-U-M, the rearmost, uppermost, midmost. That was the position which was assumed the condyle is there when the glenoid fossa is present. But this is history. Today we all know that the complex, that is the articular eminence, you also have the mandibular condyle. The entire complex is present in the antero-superior position. The second line is actually the most important line. This position is independent of the tooth contact. Whether there is an entire complement set of teeth present whether there are few teeth present, few teeth missing, or all the teeth missing. This position is independent of the tooth contact. The centric relation does not change. Centric occlusion can be established, but the centric relation does not change. So the position is independent of the tooth contact. This position is clinically discernible when the mandible is directed superiorly and anteriorly. The anterosuperior position being the most acceptable position, but what is important is the mandible is directed. The patient will never close in centric. Patient doesn't know what centric is. You ask the patient to bite, patient will go into maximum intercuspation. It's we as clinicians who guide the patient to close in centric relation. So it is directed. The mandible is directed by the clinician such that the condyle goes on with the complex in the anterosuperior position. Okay? It is restricted to a pure rotatory movement. That means when I'm guiding the patient to close in centric, the only movement that occurs is a pure rotatory movement. So if there is a rotatory movement or a rotary movement, there has to be a translatory movement as well. For understanding what constitutes a rotary movement or a translatory movement, we again come to the point that understanding mandibular movements is of utmost importance. Before we go on to the next step, let us understand the basic differences that exist between natural occlusion and artificial occlusion. Artificial occlusion generally stands for dentures because nothing exists and we are replacing everything. It also there in full mouth rehabilitation cases, either with implant retained, implant supported prosthesis, or we are constructing a new bite. That is, we are either raising the vertical dimension, maintaining the vertical dimension, but giving a new occlusal scheme to the patient. Okay. Now for natural occlusion, we do have periodontal ligament, hence the proprioception. So we exactly know that there is a stimulus, a feedback mechanism which exists because of the existing periodontal ligament. However, once you lose the teeth, you lose the alveolar bone, periodontal ligament goes along with that. Okay. So if you are giving dentures to the patient, all the teeth are supported by a common denture base that rests upon a slippery tissue, which in most of the instances is the mucosa. For natural occlusion, you have the teeth which act as independent entities. Okay. Now, in case there is some kind of an occlusal imbalance because of the periodontal ligament, because of the proprioception, the feedback mechanisms, they tend to move into the favorable occluding positions. However, in case of dentures, all the teeth act in unison because they are attached to a common denture base. Incising with the anterior teeth, that's what we all know. Masticating, grinding, or biting is the function of the posterior teeth, whereas tearing and incising is with the front teeth. You all know that. That's how the teeth are meant to be. However, if you try to do that with dentures, you not only cause stripping, but you also affect the denture stability. Okay, they're supposed to act as one single entity as far as the denture goes. What you also come across is when you have balancing side contact, which is favorable for denture stability. That's why we have balanced occlusion for dentures. You don't find that in natural dentition, because if you do have, that acts as an interference or a premature contact. Due to proprioceptive mechanisms, it's very possible that a person can avoid premature contacts and interferences. If I know that if I'm closing in a particular way, there are few teeth which are touching first, I will try to bypass that because there are proprioceptive mechanisms of the teeth. You also have the muscles, you also have the ligaments which play a role, and there is some amount of proprioception present in the temporomandibular joint. Nothing of this sort exists for dentures because there's no teeth, no proprioceptive mechanism. you cannot identify what premature contacts and cuspal interference is in the patient's mouth, you have to have a clinical remount done. Take the dentures out, mount it again, remove the high points, give it back. Malocclusion of natural teeth does not evoke any immediate response. As I just told, that even if there are any prematurities that exist, mouth, the proprioception actually can overcome that. But if the same problem exists for dentures, it does have a long-lasting consequence. You do not want that in any instance. Non-vertical forces are well tolerated and affected only the site involved. We all know that while mastication, we try our best to make sure we are enjoying the food. We definitely do not pay attention to the way we are chewing, the way we are biting, whether there are axial forces which are acting. It's impossible to give attention to all of these things. However, if there are non-vertical forces acting in dentures, it can be traumatic to the underlying tissues because it accelerates the bone resorption. For a natural dentition, the second premolar, the second molar is the favored area for mastication as far as the hard food goes. The same pressure is then shifted onto the second premolars and the first molar for denture teeth. If you try to extend that onto the second molar region, just the way it is present in a natural dentition, we tend to increase the inclination and affect the denture stability. So these basic differences have to be understood. If we try to match or simulate what exists in a natural dentition to that of an artificial occlusion or dentures without using our head, that these are the basic differences that occur, and how can we best simulate the same kind of pressures, biting forces, aesthetics, function. We have to understand these differences, and minor shift can still give us the same result. Coming to vertical determinants of occlusion, we have two factors: the posterior controlling factors and the anterior controlling factors. Starting with the posterior controlling factors, as we go most posterior point, what is it? It is the temporomandibular joint. So the posterior controlling factors actually is the condylar guidance. The way your mandibular condyle moves along the eminence, along the slopes of the fossa, determines how the occlusal morphology will be. If there is a posterior controlling factor, that definitely would be an anterior controlling factor, which in this instance is your incisal guidance. What is an incisal guidance? It is the way the lower incisal edge moves along the palatal surface of the upper incisors to reach edge to edge and go beyond. What we have to understand is, when we are talking about the occlusal morphology, the first thing is the vertical determinants. The vertical determinants, what we're trying to say is the cuspal height. If it's the cuspal height, nearer the tooth to the TMJ, more the influence of the joint anatomy on the occlusal morphology. That means the molars will have more of a role as far as the cuspal morphology goes, or the occlusal morphology goes, than the premolars, than the incisors, compared to what we want to see, the effects on the TMJ, right? So one premature interference in the premolar will not hurt that much than the same interference of the same magnitude on the second molar. What will be the effect of the condylar guidance on the cuspal height? We will check it out. Similarly, we'll be checking on the anterior guidance, the plane of occlusion, and the compensating curves. Now, just to give it in a nutshell, if you see on each of these, the cuspal height remains the same because we have to evaluate the vertical determinant. What changes is the condylar guidance, which is my posterior controlling factor. How the posterior controlling factor influences my cuspal height. Next you see is the anterior guidance. How does my anterior controlling factor influence the cusp height? Between these two extremities, we have the plane of occlusion and the compensating curves. So this entire mystery is demystified based on these 4 factors. This vertical determinant is directly influenced by these 4 factors. What role they play, we'll check it out eventually. What is a lateral translation? Lateral translation is the movement away from the centric. If I am at a relaxed position, if I take my mandible or my lower jaw to the left, that is lateral translation. To the right, lateral translation. If I move it to the front, lateral translation. But what does the lateral translation consist of? It consists of 3 factors. The amount of lateral translation, whether it has moved little or it has moved a lot to the left or the right or to the front. Direction, whether it's moved to the left, to the right or to the front. Timing, whether there is an immediate shift or a progressive shift. So what we have to understand is that if there is a mandible or the lower jaw which is moving to the left, how much it has moved, which direction it has moved, and whether the movement has been immediate or progressive. When I'm talking about immediate or progressive, is I'm talking the way the condyles move. You have the left side and the right side. If I'm moving to the left side, my left side condyle will rotate, right side will translate. So whether this translation of the right condyle is immediate with the rotation of the left side, or is it progressive? That means first it rotates, then it translates. Clear? That is all from the vertical determinants point of view. Okay, the cuspal heights. Now for the horizontal determinants of occlusion. In this instance, we talk about the cuspal morphology. That means your groove patterns, cusp tips, cusp slopes. What should be the anatomy of these structures? These are the horizontal determinants. Now the first factor which plays a big role is the condylar guidance. The question I have for everybody is this factor under our control? Can you tell the patient to move straight in a particular way, to take his lower jaw to the left in a particular way, to take his lower jaw to the right in a particular way? It's practically impossible. Okay, you cannot control this factor. However, you can simulate or replicate this factor by using either a semi-adjustable articulator or a fully adjustable articulator. So this factor, which is not under our control, we can simulate this same on an articulator and then build on the other factors such that we match this factor. Because the ultimate aim of occlusion is it has to be in a harmonious relationship with the fixed factors. Okay, so what is a condylar guidance? It is mandibular guidance generated by the condyle and the articular disc traversing the contour of the glenoid fossa. The condylar path is determined on the patient by a protrusive record and set on the articulator. It acts as a posterior controlling factor. What I'm trying to say is that this is my condyle, right? So this is the path it is following. That means the way it traverses the contours of the glenoid fossa determines how my cuspal morphology, the cuspal anatomy will be. So everyone, what you have to do is try taking your mandible forward. You will come across a point where your front teeth are contacting. If in those instances where you have your posterior teeth contacting, at this instance when your anterior teeth are contacting, it acts as an interference. So we don't want that when we are doing occlusal rehabilitation. So we have to understand this path, try to replicate the same in a semi-adjustable or a fully adjustable articulator. Clear? Yeah. Condylar pathway depends on the bony contour of the TMJ, muscles of mastication, ligaments of the TMJ, and the neuromuscular control. Now, just look at all of these 4 factors. The first factor, bone contour of the TMJ. Is it under our control? No. Bone does undergo some remodeling, which is again not under our control. Okay. Muscles of mastication. The way the muscles function, Whether the muscles are fatigued or not, it is again not under our control. Muscles do have their own muscle memory. They have their own engram. It's difficult to break it. Yes, when we are doing deprogramming, we can modify that, change that to an extent. But the way the muscles masticate, it's difficult to change that. Ligaments of the TMJ. What are the functions of the ligaments? They limit the extent of the mandible. They are the limiting factors. Can we control them? No. Neuromuscular control of the patient. Again, not under our control. So what we have to do is understand that these are the factors, or the condylar guidance is a factor which is not under our control. In those instances when there is discrepancy in the way the left and the right condyle moves, we do need to know the average value. In those instances where there is a fracture, in those instances when there is wearing off of the condylar surfaces, in those instances when there is a disharmony of the muscles of the left or the right, we need to know the average condylar guidance, because this is the value we need to set on the articulator before we go for occlusal rehabilitation, occlusal correction, removal of interferences. All these follow. First, what has to be done is understand and replicate or simulate the condylar guidance. Next is the incisal guidance. As I had mentioned earlier, it is the way the lower incisal edge moves along the palatal surface of the upper incisors until it reaches edge to edge or goes beyond. Okay. Now, what we have to understand is, when I am doing an occlusal rehabilitation, or I am restructuring the vertical dimension, or when I'm doing a full mouth rehabilitation, I have the control of the incisal guidance. I can determine what would be my overjet, my overbite, what would be the incisal edge position, what will be the slopes of the palatal surfaces of the upper incisors, whether I want heavy contacts or light contacts. I can also determine the amount of disocclusion I want. I can also determine what would be my cuspal anatomy. I can also determine the cuspal slopes I want. If I want contact on few teeth, I want no contact on the other teeth. What will be my plane of occlusion? What will be the compensating curves I am looking for? So all these things, when I'm doing my own wax up on a semi-adjustable or a fully adjustable articulator, these factors are under my control. What I'm trying to say is, just like condylar guidance is not under my control, incisal guidance is under my control. So my job is to make sure that the anterior controlling factor or the incisal guidance blends with what exists, or the condylar guidance. That is my aim. Once I understand my aim, it's only when I start with my methodology. Okay, so what is incisal guidance? This is defined as the influence of the contacting surfaces of the mandibular and maxillary anterior teeth on the mandibular movements. Again, what is GPT? Glossary of Prosthodontic Terms, the Bible in Prosthodontics. Incisal guide angle. What is an incisal guide angle? It is this angle. Okay, it is formed by the intersection of the plane of occlusion and a line within the sagittal plane determined by the incisal edges of the maxillary and the mandibular teeth. Okay, so it is this angle and this angle. When I trace it back, this forms an angle. This is my incisal guidance angle. Clear? Yeah. What does it depend on? Phonetics, aesthetics, shape of the residual ridges, ridge elevation, interalveolar distance. How? Phonetics. We have different sounds, right? The F sound, the V, sound, the S, Silverman's closest speaking space. So these sounds help us understand where will my incisal edge be. If F gives me an idea that the incisal edges will have to be flushed in with my inner vermilion border of the lower lip. S gives me an idea that the upper and lower incisal edges approximate but do not touch. Otherwise, if they touch, I have to create some distance. If they overlap or if there's an excessive space, it will be whistling. So all these things are important as far as phonetics go. When we talk about aesthetics, we have to understand the smile line, the lip line, the speaking line. All these things play a role. So we have to correlate phonetics with aesthetics. Shape of the residual ridges, whether it's an ovoid ridge, it's a squarish ridge, it's a combination ridge. Based on that, the morphology of the teeth will vary. Ridge relation, if it's a class 1 relation, a class 2 relation, or a class 3 relation. In those instances where we think that the ridges are almost edge to edge, we can still get onto a class 1 relation in our teeth arrangement, wherein we give minimal overjet and overbite. Interalveolar distance, is this important? Of course it is, because this gives us an idea whether we have adequate space, we have inadequate space, or we have a lot of space present between the ridges. Now let us look at all three instances. If we have adequate space, means we can choose good amount of teeth, good number of teeth. We don't have to compromise any teeth. We can choose teeth which are long enough such that we have a good smile line. If we have reduced amount of space, we'll have to trim our teeth a lot because we need space for the acrylic as well. If we have increased space, I know that I'm going to create something which is more like a gummy smile, because even my alveolar mucosa, which is overlying along with my denture base, that also is visible. So I need to have an average value. Always keep average values in your mind. In those instances where it's difficult to fabricate things, it's difficult to correlate with things, the average value is an arbitrary center value. It's taken as a mean. This does come to the rescue. What is a plane of occlusion? The average plane established by the incisal and the occlusal surfaces of the teeth. I draw a line along all the incisal edges and the occlusal edges. This gives me my plane of occlusion. Generally, it is not a plane, but represents the planar mean of the curvature. If I have my compensating curves, this plane wouldn't be straight. It will be tilted this way. It goes up, goes up. Okay, we'll come back to the plane of occlusion as well. Okay, is this clear now? This is the plane. I'll just play it again. This is the plane. So it is just the line which is followed, which actually is the planar mean of the curvatures. How do we measure this? This is established anteriorly by the height of the lower canine. If you see here, my lower canine always coincides with the commissure of the mouth. Even if I'm doing a jaw relation, I have to make sure that when I'm having my lower wax rim, this is where my lower canine tip is. So this gives me an idea, right? And we always make sure we are following the alar tragus line. So our maxillary rim will be following this plane because it has to be parallel to the alar tragus or the Camper's line. On the other hand, when we ask the patient to close or bite or guide the patient in centric, we have the upper and lower wax rims flushed in. That means you have the retromolar pad here. So this is the line which is parallel. Okay, so we have to get that plane of occlusion. Okay, so this is my plane, which is always parallel to the alar tragus line or the Camper's line. Now, what is Christensen's phenomenon? Before I actually start making you understand what this is, it's a very simple exercise. All of you bite, just bite your teeth. Yeah. Now slowly try to take your lower jaw in the front until your upper and lower teeth meet edge to edge. Once they meet edge to edge, what is commonly seen in most of the instances is that your posterior teeth are not in contact. There's a gap which exists. It is this separation which is the Christensen's phenomenon. Okay, simple to understand?
Yes.
Coming to the compensating curve. As I mentioned that if I draw a straight line, this is my plane of occlusion. But if you see here, there is a small tilt that occurs. This acts as my compensating curve. The compensating curve generally begins with the distal half of the first molar, extends on to the second molar. That means if I see this is a straight line, I will have a small upper tilt onto the distal half of my first molar this will extend onto my second molar. This is my compensating curve. Why do I need it? I need a posterior stop. Because if this is a straight line, I'm effectively giving monoplane occlusion, where I can chew, but I do not know the extent of my distal limit. Anteroposterior curving in the medial plane and the mediolateral curving in the frontal plane within the alignment of the occluding surfaces and the incisal edges of the artificial teeth that is used to develop balanced occlusion. Now, what are these? They are the artificial components of the curve of spree and monsoon when found in the natural dentition. Now, can you see this? This is a curve. Now, I was talking about this slope. In the next slide, you will see this even better. Now, why do we need this? Is we need balancing contacts. Now, if I see this is my canine, 2 premolars, my plane of occlusion is straight. However, if I see my first molar, there is a tilt that occurs, and the tilt continues onto my second molar. I can actually trace a curve here. My plane of occlusion is straight. This goes above the plane of occlusion because this is giving me a compensating curve. Okay, so this actually begins with the first molar by raising it at the distal level, continuing the curve with a smooth further rise onto the second molar. This is what I always talk about. This is a monoplane occlusion. That is, I did not give any kind of compensating curve. This remains a straight line. But then if I want stability of my denture, if I want balanced occlusion, I can never have my teeth contacting like this, because if I have to give this a tilt and I take it protrusively, I will still have contact of these teeth. Because I want stability. Balanced occlusion bilaterally in a complete denture gives me additional stability. Okay? Coming to the inclination of the cusps. If my cusps are tilted, it is inclined. Okay? So any inclination is the angle between my cuspal tip or the inclination along with a flat horizontal surface. Now, the inclination is very simple. I just mentioned about the compensating curve. I can either make it steeper by raising the distal surface. I can make it reduce by lowering the distal surface. Or I can make it flat or monoplane flat by keeping it parallel to my plane of occlusion. Okay, so mere tipping can produce the compensating curve. Why do we give compensating curves? The name says it all. It is compensating the curve that exists in natural teeth. In my artificial occlusion, I have understood the inherent differences that exist, which are already absent in my artificial occlusion. But to simulate what exists in natural dentition, I have to create all of these. Till now, we were talking about artificial occlusion. What do we do? How do we go about everything? But we do have to understand that artificial occlusion is created. How do we create something when we know what already exists? What exists in a natural dentition is for all of us. Everybody who has teeth have got natural dentition will have few particular factors which exist. Few factors which should be there classified as ideal occlusion. But not all the factors which are there in ideal occlusion exist in natural dentition. But is that a problem? No. We want ideal occlusion when we are creating, rehabilitating a patient. When we are creating a new occlusion, we want to go as close as possible to ideal occlusion. But when we have natural dentition, when we have no problems, we need not go for ideal because it still holds good in natural dentition. So I'm talking about ideal occlusion. What exactly is this ideal occlusion? The few factors are centric occlusion is in harmony with the centric relation. What does this mean? When I'm asking the patient to close in centric relation, I'm guiding the patient in centric. In natural dentition, few teeth will contact. Okay? Because centric relation need not be coincident with centric occlusion. That is, maximum intercuspation is not happening at centric relation. There is a small glide which exists from centric occlusion or centric relation to maximum intercuspation, which is fine in natural dentition. But when we are making an ideal occlusion or doing a full mouth rehabilitation, this should be the first aim. We should try to have centric occlusion at centric relation. In centric occlusion, the supporting cusps of all posterior teeth occlude with the marginal ridges, barring the distobuccal cusp of the mandibular molars and vice versa. If it's distobuccal for the mandibular molar, it will be mesiolingual or the mesiopalatal for the maxillary molars. All of them occlude with the central fossa of their opposing arch. During protrusion, the posterior teeth should disocclude. This is an exercise which I made all of you do. This is present in almost all instances, but as you grow older, your teeth start wearing off, right? So what happens because of this is the disocclusion or the separation that exists between the posterior or the behind teeth starts lowering down or starts decreasing. At one point of time where the wearing of the teeth has reached to such an extent that you move your teeth to any side, you have teeth which are touching. Okay, so that is the instance where the vertical dimension is lost. We have to regain the vertical dimension. When we want to regain the vertical dimension, we have to rehabilitate the patient. When we rehabilitate the patient, what should be our aim? To create ideal occlusion. Is that clear?
Yes.
Next point, tonic activity of the masticatory muscles should be healthy. We have to make sure that the occlusal scheme which we are giving is in harmony with the entire stomatognathic system, because the teeth have to blend in with what exists. We do not want interferences. We do not want muscle soreness. We do not want TMJ pain, right? So the aim has to be to blend with what exists. During lateral movements, that is when you move to the left, to the right, to the front, the teeth on the non-working side should disocclude. What's the non-working side? If I move my lower jaw to the left, so when I'm moving to the left, my left side is my working side. The right side is the non-working side. So when I am moving my lower jaw to the left, the right side should not have any contact. The left side which has contact should ideally be the canine alone, or can be the canine with the premolars, or can be with the canine premolars and the mesiobuccal cusp of the first molar. What I am trying to hint at, either it is canine alone, the canine guided occlusion, or it's canine with premolars and the mesiobuccal cusp of the first molar, group function occlusion. That's why these terms are introduced earlier, so that you start picking up as and how we go ahead. The dentition is in harmony with the basal bone and aligned such that functional occlusal forces are directed along the long axis. The ideal aim at any instance is axial loading. We always want the forces along the long axis of the teeth. As long as they remain along the long axis, what we see is that there is an axial loading. There is absolutely no problem that exists. Okay, there is uniform distribution of the forces. The moment they become non-axial, that's when we encounter stress concentration. Few areas receive increased stress, which leads to increased bone resorption. So our ideal aim should be to have axial loading. This is what I was talking about, interocclusal distance. That is the separation which exists between your upper and lower teeth. Simple exercise. When we are sitting at a rest position without eating, without swallowing, that's deglutition or any other motions, our teeth don't contact. The teeth contact only for a limited amount of time. When we bite, when we chew, when we swallow, we still have to contact, right? For all these things, the teeth contact. But when we are doing an occlusal rehabilitation, our aim should be that at rest, the vertical dimension at rest, we do not want the teeth to contact. We need spaces that exist between my teeth. Do we just want the spaces to exist? No, we want uniform spaces to exist. Okay, because if it's not uniform over a period of time, we will encounter premature interferences. We do not want to cause any abnormality to the masticatory, deglutition, speech, aesthetic, and other functions. We do not want that. We do not want to give any signs or symptoms of pain or dysfunction from any component. What are the components? The muscles, the temporomandibular joint. We do not want them to be affected just because we've done something to the teeth. Okay, so tomorrow we get back for session 2. Tomorrow we'll be talking about occlusion in complete dentures in details, occlusion in fixed prosthodontics in details. Today, basically, we wanted to introduce few terms so that you get acquainted with what the terminologies will be as the session progresses. Basic idea was to differentiate the components, that is the vertical determinants and the horizontal determinants, to know what we are looking at. The posterior controlling factor, the anterior controlling factor, how they play a role, what acts as an interface between the two, which is the plane of occlusion, and my compensating curves. How can I play around with the factors of phonetics, aesthetics, function, ridge relation, interalveolar distance to determine what kind of overjet, overbite I want, what will be the amount of visibility as far as my teeth and denture bases go. I have also understood and tried to make you understand that what are the problems we will encounter if these basic things are not corrected. We also touched few things about natural dentition, how the periodontal ligament plays a role, how the proprioception plays a role, what happens if we are not anywhere close to ideal occlusion, we still can function in the mouth without any problems. I also explained the ideal occlusion or the ideal scheme we want to reach, such that if we are encountering any case for a full mouth rehabilitation or a full mouth reconstruction, be it with implants, without implants, what is the aim and objective we want to achieve. Giving an overview for session 1, we meet tomorrow for session 2. A very good afternoon once again to everybody back home in India. Very early morning to people in United States and mid-morning to people in Europe. We shall meet tomorrow. Looking forward to that. Thank you all.
Thank you, Dr. Sagar. Just get off the screen share so we can say goodbye to you. Yeah, excellent presentation, well laid out, concise, clear, and I hope to be able to grow the audience, certainly Indian dental students, as well as dental students anywhere. It seems universal. So we'll welcome you tomorrow, and I guess you'll be covering terminologies used in occlusion, correct?
Yeah.
Okay, doctor, we'll see you tomorrow.
Pleasure. Looking forward to seeing you tomorrow. Take care, John. Bye-bye.